Okay. So, you guys dah semayang makan semua kan?
Dah.
Dah doktor.
Okay, good. Sekejap. Sekejap sini. Sekejap. Oh, here. Okay. So, we've got 2 cases. Satu hematologi, satu lagi respi kan? Okay, siapa nak start dulu?
Hemato dulu lah doktor.
Okay, hemato, okay. So the outline, I mean the flow of the slide today is so one person will present. Everyone have to listen carefully. Look at what good points you can learn, okay, from the presentation in terms of the skills, presentation skills, the point, the word used, the phrases used, and also the flow of the presentation. And then in the same time you have to jot down specifically what can be done better. Okay, for example, like I need quotes. Okay, for example, like okay, the person have mentioned there is no there's no fever, for example. Then you have to quote. You have to quote. you have to quote from the presenter lah. I tak nak something yang vague macam tu. I nak something yang specific. Okay. Example from the presentation itself. Okay. So and we going to all of you need to give feedback. So it have to be. We're going to take turn lah. I'm going to call names, and you guys need to give feedbacks. And finally, macam tu, and then we conclude lah the session. So start dengan hemato first. Okay, would you like to give us some brief idea what the case is before you start?
The case, the diagnosis doktor.
Tak, the case is about what? Just rough idea.
Rough idea kan?
Huh.
Patient presented with fever, but once investigation was done, it turned to somehow ada underlying dia.
Okay, good. So the initial presentation is fever, and then finally it turns out to be hematological.
Yes doktor.
Okay, so let's begin. Okay. Sir, kita start dengan Umul Kitab Fatihah. Kita start lagi. Okay. Kazim.
Okay.
Boleh.
Sekejap, saya tinggal. Dah nampak ke?
Nampak apa?
Dah nampak slide.
Dah nampak dah eh?
Nampak?
Dah.
Okay.
Oh, so you gonna slides lah. Are you going to read?
Oh.
I thought long case macam bukan present ke?
Oh, okay.
Tak apa. Kalau you nak ni I lagi suka.
Okay. Okay, tak apa. You guys buat slides ke? Dia ada semua buat slides ke?
Yes. Buat slide juga.
Ya ke? Boleh ke? Saya tak cik lah kalau buat presentation buat slides. Kan? Okay, unless okay, tak apa. This time okay. Okay, good. Okay, continue.
Okay, bismillahirrahmanirrahim. So this is basically ada identification of my patient. Name Adik Khairu Anwar, age 1 month, from Kemaman, Terengganu. So basically the chief complaint is he is 1 years old, 8 month Malay boy, was referred from Darul Makmur Medical Center to HTAA with the complaint of fever for 5 days duration associated with pain and poor feeding prior to admission. So basically on day 1 of fever, he was apparently well until 5 days prior to admission, whereby he started to have fever. So the fever is said to be high graded by his mom with documented temperature of about 38.9 degrees Celsius, but it is not associated with chills and rigor. So his mother claimed that the fever is on and off and particularly has early morning spike. He was given Panadol and sponging was done. However, it was not resolved and the fever is associated with pallor and poor feeding. So, regarding the pallor, his mother noticed that her child would look paler since the second day the fever started. So, his mother also stated that previously, when her son developed fever, there will be facial pallor also. However, she denied any history of rashes, easy bruising, or bleeding tendency of the patient. And the pallor is not associated with any shortness of breath, weakness, and lethargy. There is also no family history of blood disorder. So, his mother also claimed that uh, the child refused to eat since the third day of fever. He can only tolerate soft food and liquid, but in small amount. And she said that the diaper changes also reduced from 5 times per day to 2 times per day since the third day. He also seemed to be irritable and unable to sleep due to the illnesses. However, the child is still active and play well during the day. There is no dry lips and sunken eyes noted. Otherwise, her mother denied any history of URTI symptoms such as runny nose and cough. There is also no history of rashes, injected eye, nausea, and vomiting during that day. So on day 4 of illnesses, he started to have rapid breathing that is associated with noisy breathing and nasal flare. So his mother also noticed the slight abdominal distension on his body, and he was also become more inactive and lethargy during that day. Thus, due to that condition, his mother brought him to the private clinic later at night. He was given again Panadol and been nebulized one time at the clinic. So at this particular clinic, his mother said that he request the apa kata he request from the clinic to do the blood investigation to his son, and the blood result she said that to have low blood cell with high high white cell count. So in view to this matter, the mother, was advised to go to the hospital. So on the day 5, which is the next day, his mother then brought him to Darul Makmur Medical Center for further treatment. So there, the doctor informed that his tonsil was enlarged, and during that time, he said that her son was diagnosed with infection on the tonsil and also on the throat, which I presume to be tonsillopharyngitis. So again, the blood investigation was done at the Darul Makmur Medical Center and revealed the same result as the clinic, which is low red blood cell count and high white blood cell count. And due to this result, he was then referred to HDA to done further investigation. So on further questioning, uh, revealed that started 4 months ago, adik Khairul Anwar frequently had fever almost every week, and each episode of fever lasted for about 3 days. Lagi however, for the previous episode of fever, usually, it will relieve by medication. Only for this current admission, his fever lasted for more than 3 days. So he also had history of traveling to Kedah, Johor, and Cameron Highland about 1 week prior to the illnesses. Otherwise, there was no history of sick contact or family member with the same symptom. and he does not live in dengue-prone area. So for the systemic review, basically none is remarkable, it is unremarkable. So for the past medical history, this is his third hospitalization. So his first hospitalization is about 13 months ago due to the seizure. His second hospitalization is about 10 months ago due to circumcision. Otherwise, it was uneventful. So for the drug history, he is not on any medication except for the Panadol itself. Otherwise, there was no history of drug or food allergy, no history of taking other supplement or traditional medicine. So for birth history, basically the antenatal is uneventful. For the intrapartum, he was born at 37 weeks via SBD in Kuantan Medical Center with the birth weight about 2.6 kilogram, and the birth was uneventful. So for the postnatal, it was uneventful. No blood screen was done to him. So for the developmental history, currently he can walk independently and can throw balls without falling and sit on the chair. For the fine motor, he can scribble spontaneously and build tower of three. For the speech, he can say 2 to 3 meaningful words such as mama and baba, and can point to 2 to 3 body parts. For the social, he can imitate housework, use phone, and also play well with other children. So for the nutritional history, he was breastfed until now for about every 3 hours. He also start weaning at the age of 6 months old. Currently, he can take adult diet such as rice, chicken, fish, and vegetable about 3 times per day. So he is not picky eater, and he not eating any weird thing. Pika. So for the vaccination history, the immunization was completed up to his age. So family history, it was a non-consanguineous marriage. He is the only child. His father has no non-medical illness, same to his mother. However, it said that his grandmother on his father's side has diabetes mellitus. Otherwise, all other family members are healthy. There is no history of malignancy or blood disorder run in the family. So for the social history, his father is 28 years old and work as wedding planner with the income range from about 1,000 to 4,000 per month based on the job availability. So his mother is 28 years old and a housewife. They live together in single-story house at Kampung Geliga, Kemaman with basic amenity. And his father is an active smoker, smoke about half box per day. Otherwise, both of his parents are non-alcoholic or no drug abuse. So for the physical examination, it was done on the first day of admission at the HTA. So on general inspection, basically the patient was lying on the bed, alert and arousable, and there is a snow heard when he breathed. The patient looks pale, but not sinus or jaundice. There is no dysmorphic feature looking in this patient, and there is a cannula on the left dorsum hem with no active infusion. Otherwise, the patient is not in pain or respiratory distress. The hydration status and nutritional status is also good. So on hand examination, he had a warm periphery but with palmar pallor. However, there is no clubbing, no koilonychia, no flapping tremor, and also no peripheral cyanosis. The CRT is less than 2 seconds. BCG scar was normal on the left arm, not indurated. So on eye examination, there is conjunctiva pallor but no jaundice. On mouth examination, oral hygiene was good. There is no angular stomatitis, no potted tongue, and no glossitis. However, on the tonsil examination, there is an enlarged tonsil, presumably grade 3 noted in this patient. Otherwise, there is no leaf adenopathy and no angioedema. So for the blood pressure, for the vital sign, the blood pressure is about 18, apa kata, hypotension, slightly hypotension. For the temperature, normal 37, respiratory rate about 26, hypo. For the pulse rate, about 90 beats per minute. SpO2, 98 under room air. So anthropometric measurement, the weight is about 9 kilo below the third centile, and the height, the length is 81 centimeter between the third to 10th centile. So for the systemic examination, basically for the abdomen is slightly distended but moved with respiration. There is no surgical scar or dilated vein noted, and the umbilicus is centrally located, not inverted. So on palpation, the abdomen was soft and non-tender. However, there is a palpable liver 2 cm below the costal margin. There is also apa kata, the tip of the spleen is also palpable. However, the kidney were not blockable. So on percussion, the abdomen was resonant with no shifting dullness, no fluid trail. However, there is a dull throat space. And on auscultation, bowel sound was heard. So basically, the other systemic examination are unremarkable. Apa lagi? So for the summary, Encik Pulok, adik Khairul Anwar, 1 years old, 1 year 8 month old Malay boy with no known medical illnesses, was referred from Darul Makmur Medical Center due to the fever for 5 days duration, associated with pallor and macam mana nak kata, suspicious blood test result lah. And he also had history of recurring infection and pallor almost weekly since 4 months ago. So on physical examination, revealed that patient is anemic, were associated with hepatosplenomegaly and dull throat space. No jaundice, sign of iron deficiency anemia and leaf adenopathy noted. On throat examination, the throat is injected with the tonsil grade 3. So basically, up until now, my provisional diagnosis will be thalassemia with concurrent infection of acute tonsillopharyngitis, because the patient presented with fever and pallor, and on physical examination, patient was presented with hepatosplenomegaly. However, for the points again, there is no family history of thalassemia and no jaundice presented in this patient. So other my differential diagnosis would be iron deficiency anemia, leukemia, and also lymphoma. So basically, kenapa tersekat
Kenapa slide sekat ke apa?
Sekat ke?
Tak ada, okey je.
Tak ada. Sekejap. Dah boleh lah. So basically, the investigation that been this patient, the FBC reveal HB 9 gram, which is low, with total white blood cell count 42.6, which is 4 times the upper limits of normal. So for the peripheral blood film, show mild anisopoikilocytosis, present contain cigar cell, target cell, and also teardrop cell. Serum iron study shows low iron but normal ferritin. So the throat swab show the growth of Streptococcus pyogenes. HP electrophoresis was done, and revealed that patient had beta thalassemia. And for the viral antigen test, basically it is non-reactive and bone marrow aspiration basically not done in this patient. But to exclude my other differential diagnosis, bone marrow aspiration should be done in order to look the presence of hypercellularity and blast cell for the leukemia. So that's for the investigation. But for the management, I will just say about the general management for the thalassemia. Regard the general management about the patient with thalassemia. So if the patient presented with symptomatic patient is symptomatic or HB is low than 8 or 9, we need to do the blood transfusion. So there is, according to Paeds protocol, there is a target for the blood transfusion in order for the patient to experience normal physical activity and also normal growth. So basically the target for the blood transfusion is to maintain the pre-transfusion HB between 9 to 10. Post-transfusion HB is between 13 to 15, and in the meantime between 12 to 12.5. So if the patient already undergone the blood transfusion therapy, we need to do at the same time the iron chelation therapy in order to get rid the excess iron in this patient due to the blood transfusion. So basically the agent that can be given to this patient is desferrioxamine. Okay. And apa lagi orang kata? Other management that can be done in this patient is the in general is the splenectomy. Especially if the patient experience hypersplenism, which is the patient require more blood transfusion than its normal time to maintain the HB level. So for his acute tonsillopharyngitis, basically there are conservative management of it, such as analgesic and also antipyretic to relieve fever and also pain. And since the patient had poor feeding, maybe due to the painful during swallowing, we need to ensure the adequate hydration and also nutrition. And in order to tackle the infection by the Streptococcus pyogenes, we need to administer antibiotic to the patient, either penicillin based or cephalosporin based, such as ceftriaxone. So basically, that's all for my presentation, Doctor.
Okay, good, good. Where do you get these slides?
A slide,
You buat sendiri
template, Doctor.
Lah template dapat mana?
Apa?
Where do you get the template?
Dalam YouTube, Doctor.
Maksud dia macam mana? You download dari YouTube?
Saya download dari YouTube. Kalau Doktor nak template, saya ada je.
So dia ada banyak template lah.
Dia ada satu je.
That's very nice, no? Okay, anyway, good. Okay, any comments? Start from Amirul Idlan. I want you to highlight what good about the presentation, and then after one cycle, then we talk about what can be improved, and then we conclude. Okay, Amirul Idlan.
So the positive part about Haziq presentation is he had a good chronological order of the history of presenting illness. I can see the clearly where the symptom go day by day. Okay, that's the good part. I think that's it. And he also rule out any bleeding disorder. Also rule out jaundice, to rule out any hemolytic anemia. Okay, so all part of the anemia, Haziq has covered about it. Okay, that is the good part.
Okay, good. Next is Abil Burhanuddin.
Yes.
Okay.
There are many good points for Haziq presentation, but I just want to highlight about when he's telling about the chronological order tu, he used the same unit like macam 5 days ago, like
Hmm.
on the means on during fever, he tells that on day 4 of fever, there is rapid bleeding like that. Means
Hmm.
there is one reference point
Okay, good, good. That's a very
easy
good
to
point.
understand.
Hmm.
Uh, other than that, that's all I want to highlight.
Okay, good, good. Next, no Nadian Ardila.
Uh, for me, the good part is because his presentation is one by one, so it's not too rush or not too slow. That's the good way for us to stay focused. And if I want to add, maybe I want to know the detail about the recurrent fever. Is it the same characteristic as this one, apart from the duration, as well as is the throat injection, is it recurrent as well or not?
Uh,
And
Okay.
for the throat infection, this is the first time. But
hmm,
for the previous apa kata fever, there is the same characteristic, but usually lasted for about 3 days, as compared to this one 5 day.
Okay,
okay.
okay, okay. Okay, okay, okay. Good, 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 good. Okay, Nur Ain Zuhari. What's good about the presentation? By the way, how long? I mean, how many minutes you've got in your exam for presentation?
We actually have the modified long case, new way of exam, doctor. So we haven't got the real time of our exam. How many minutes? It's about 30 to 40 minutes,
For
including the discussion.
presentation or
Yeah.
including discussion? Okay, okay.
Hmm.
Okay, so okay. Okay. Next, Zur Ain Zuhari.
Okay, for Haziq presentation, like Ijan said, I like that I can follow the sequence of the story, and also I also like that what was it? Haziq highlights the how is it highlight the reasons or the reasons that he referred to hospital. Uh, so that we understand the causes or the reason for admission tu very clear.
Hmm. Okay, 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 okay. Okay, okay, understand. Okay. Uh, okay. So let me add up. Uh, I think I like the flow. I like the flow of the presentation. And I think there's a lot of thinking being put in the presentation. I'm not sure whether the same thinking has been put during the clerking, but definitely there's a good systematic way of thinking being put during the presentation. For example, you've mentioned there's no rashes, there's no injected eye. When you present about the history of presenting complaint for rapid breathing, kan, you said that he's got rapid breathing kan, if I'm not mistaken. SOB kan, uh,
Yes.
kan.
Yes, yes.
So you did mention there's no rashes, injected eye. I think you are trying to rule out measles. Am I right?
Yes, doctor.
So that's very good. And then about the payload, I mean you clump all the positive and negative, important negative together. I mean that shows that you are thinking about thalassemia. You are thinking about hemolysis. That's very good. Okay. And then uh, the description of the flow of referral too. That's very good as well. Started from the GP, and then to the Darul Makmur, and then to HTAA. And then the rest I think mentioned by your colleagues. Good, good. Okay, now what can be done better? Okay, we start with this one. Rahil Yusri. Okay, Rahil, what can be done better?
Well, I think because he mentioned abdominal distension in rapid during rapid breathing. new symptoms. Well, is it? I would like him to clarify. Is it the abdominal distension only happen during the rapid breathing, or the abdominal distension is another symptoms that has happened before? Like, is it? Why do you put it in the rapid breathing?
No, because nak jematkan slide sebenarnya. To be clear that the abdominal distension, his mother realized happened for about 4 months ago.
Mm-hmm.
Started to increase in size. No, started to become more distended than before. Macam mana nak kata? Macam tu lah.
I understand. Okay, I understand.
Ah.
Okay, thank you. Just to clarify that maybe for another symptoms we should put it macam tempat lain sebab takut confusing. Tu je. Otherwise that's, I think it's good. He's confident enough.
Okay.
Nothing much.
Okay, good, good. Good. I agree with that. Okay. By the way, actually, I want to add on the what good about the presentation. You've been very systematic at some point, okay, but at another point there is a bit of incongruence, I would say. Tapi however, there's a very good systematic way of presentation. For example, when you describe Pelo, I really like it. Okay, you are quite systematic in a way that you presented. I think the way of thinking is when you say about Pelo, you mention the possible causes, kan? You mentioned the possible causes. For example, point that leads to possible causes of Pelo. For example, you've mentioned macam tadi yang you kata apa kan? No bleeding tendency, no rashes. Apa lagi you mention? No rashes. Okay, yang tu lah. And then you did after that you explore the possible complication of Pelo, which is anemia lah, symptomatic anemia. Then you also mentioned, however, there's no and on top of that there is no breathlessness, no lethargic. So there's a I mean there's a separate, you separate them, all the symptoms and signs, all the symptoms according to the possible causes that can help us to think, okay, this guy is thinking about is it possibly become due to hemolysis or due to bleeding, and then the complication of anemia itself. So that's very good, no? Okay, Shaira, Nurul Shahira, what can be done better?
So I think for the part the patient had a frequent fever since 4 months ago. So I just want to know more details regarding did the mother bring the son to any clinic, because frequent fever for almost every week, and then any blood investigation done instead of giving medication. So I think I want to know more about that.
So before this, no, only sponging and apa kata bagi PCM je dah relieve the fever. Lagi pun sekejap dia punya fever waktu dulu walaupun recurrent.
Okay, around 3 days kan you mention. Okay, good. Okay, I agree. Can no Shazwani? Okay, good.
I think I did not really get, because at first patient having fever and also having prolonged fever like for 5 days, and also having failure, and I've been thinking of acute lymphoblastic leukemia, as it is the most common childhood malignancy, because some of the symptoms can suggest of malignancy symptoms, right? But how can at first place he tell that the diagnosis will be thalassemia instead of other disease? Because there is no family history of inheritance, family inheritance of thalassemia or pale.
Because first of all, I do not really suspect the lymphoma because there is
leukemia.
leukemia.
acute lymphoblastic leukemia.
Yalah.
Macam mana nak kata? Uh,
It's in your differential lah, but to be, I think I really agree with Nur Shazwani. It should be at the top of your list.
sebab macam mana saya nak kata, dia saya tanya dia punya signs of bone marrow suppression semua tu, no bleeding tendency semua tu, no bone pain. Macam mana saya nak kata? Look, macam mana nak kata yang tu?
But you have to bear in mind this child got, like you've mentioned, got two cell line involvement kan. So then any child that got like more than one cell line involvement, either cytopenias or cytosis, you have to think of marrow punya issues lah, something wrong with the marrow. Okay. And when we talk about marrow, then at this age, the thing that worries us the most is actually, of course, leukemia lah kan. So with the high total white, up to 40, which is quite rare in common infection. There are few infections that can have very high total white, especially associated with pelo. But definitely we have to think about ALL leukemia. Because the mother highlight because at the GP pun they highlight high total white, and then at the mama also highlight high total white. Then because you highlighted it, then usually high total white we will think of cancer. Then that's why it has to be at the top of the list. Okay. That's, I agree. Okay. So let me add. I like the way you describe the fever. Okay, that's quite extensive. You even mentioned early morning spike. Okay, a lot of time people say fever, they will just mention about chills and rigors, documented temperature. But you can add on. Okay, you can add on description of fever. For example, like you can mention this is an intermittent fever, quotidian fever. You can actually describe the fever. There's a lot of way to describe fever. Okay, itulah. And then mana tadi? Okay, so I do agree with some of your friend that sometimes you have to separate the HOPI clearly lah. Macam especially the abdominal distended dengan respiratory complaint tu, macam tak berapa match unless kalau you nak associate, you nak relate the abdominal distension that with the respiratory, means you want to say that the abdominal distended causing the breathing difficulties lah, because of course bila you ada distended abdomen kan, they can spleen your diaphragm, especially you ada hepatomegaly, splenomegaly, they can spleen your diaphragm. One of the symptoms is breathing punya problem. And then okay, yang tu lah, I rasa the HOPI is quite okay. The physical examination, however, you've mentioned about flapping tremor. We rarely do this in young children now, 1 year, 8 months old especially. And then the rest okay kot. I think the rest physical examination is okay. You did mention about the trap space. Okay, the trap space. Cuma at 1 year 8 months old, actually 2 cm below subcostal margin is quite okay now. Liver 2 cm below subcostal margin is considered, we still can consider it's normal lah, because not even 2 years old. Usually after 2 years old, then if it is more than 2 cm, then we might be a bit worried. But 2 cm less than 2 years old is quite normal. But the dull trough space is subjective, but that signify splenomegaly. Okay, that's very good. The rest, okay. Anything else? among your, I mean, any of you want to add on, especially on the management, the diagnosis, differential diagnosis, investigation, before I proceed? Ada? Okay. So in terms of management kan, in terms of investigation, okay, any kejap. Okay, so bear in mind, anything you do, the first thing is the acute management first. Okay, because this child is considered acute. This is an acute presentation, so always manage acutely. Investigation also investigate something that is acute. Okay, so the acute presentation is fever and pelo kan. So investigation should be along that line lah. Investigation for fever apa dia? So infective screening, because Hep B, Hep C yang tu the third line lah. I would say that is the third, fourth line. Okay, the first line will be FBC, and FBC you have to, the main thing is patient datang dengan pelo. Okay, what information is very important in the FBC? Patient with pelo, anyone? In the FBC, what you have to stress on? First hemoglobin, and then what else?
Blood cell.
White blood
MCV.
count. Okay. Yes, MCV, MCH kan. MCV, MCH, lactic count, and also RBC. This is the five things lah. HB, MCV, MCH, RBC, and lactic count. These five is very important. You have to mention this whenever you mention about anemia. Okay, because it give you it will give you the diagnosis. Okay, I just need these five to make up my diagnosis. Okay, and then other things like because it's pelo, then you also need to have some LFT lah, so that we know if pelo with jaundice, some degree of jaundice. Usually thalassemia they come with jaundice lah, a bit of jaundice. And then infective screening. Okay, very good. You've mentioned about the throat swab. Okay, actually that's the first line. Cuma kita rarely do throat swab here in Malaysia. And cuma culture tu usually later lah. It's a second, third line punya investigation. It's important investigation, but you have to arrange it later lah, because we rarely get the culture very early on kan. Okay, and then FBP, very good. But the main thing you want to see in the FBP is, in this case, what is the main thing you want to see in the FBP?
In case thalassemia ke doktor?
Tak, in this particular case lah. Okay, because I think because your thought is thalassemia kan, that's why you presented thalassemia punya ni. But actually in any case with high total white, your first the first thing you want to look at the FBP is the blood cell. Blood cell. So you have to mention no blood cell. Okay, no blood cell have to mention. Okay, no blood cell, no abnormal cell, and then you mention all the cell that might suggest the ni lah, thalassemia. HB analysis, usually I don't want HB analysis, because you don't get HB analysis after 1 month. Okay, only after 1 month then only you get the results. Okay, and then finally the management, again you have to focus on the acute first. So what is the acute management? Okay, good. You mentioned about the nutrition, about the fluid, antibiotic, fever and pyrexia management, and then splenectomy tu, yang tu Kalau you cakap tu it cause you more trouble than good. Okay, because you are digging your own grave. Because nowadays we are going away from splenectomy. There's a lot of complication. Actually, and people die because of splenectomy more than people die because of thalassemia tu itself. I mean, the complication of splenectomy tu is worse, far worse than complication of thalassemia. Okay, unless kalau, I mean, if you got good control of thalassemia, you'll be more likely to live up to 60, 70. But if you do a splenectomy, you are more likely to die at 30 or 40. Okay, because of the secondary immunodeficiency. So we don't talk about splenectomy nowadays, especially in pediatric lah. So untuk thalassemia, even chelating agent is far down there because patient, this is a newly diagnosed patient, 1 year 8 months old, most likely is beta major lah. Beta, most likely this is beta, this is intermediate lah most likely. Either dia kata beta kan dia sebut. Then most likely this is beta intermediate punya beta lah. Not beta major, because beta major they present very early lah, at 6 months old. By the time, by 1 year, they usually already transfusion dependent. Okay, anyway, so tu je lah kot. And whenever you talk about management, okay, always talk about A, B, C, D. Tahu kan A, B, C, D? Okay, airway, breathing, circulation. Because this child you stress on the snore kan, you kata patient ada snore. So bila you cakap patient ada snore, you know what I'm thinking of? Because you mentioned about snoring. I thought you going to, your differential will be, you know, like things that affect the upper airway, croup ke. Because croup, they can get high total void tau, croups. Usually it's lymphocyte lah. And then itulah things along that line, tapi it's not. Because you stress on the snore tapi you tak mention anything yang we worried about snoring. Okay, so itulah, always start dengan airway, breathing, circulation, and then any disability, neurological, then only the other management, the pyrexia, the nutrition, antibiotics, and then finally baru the chronic once diagnosis obtained. Confirm lah, okay? Okay, ada soalan? Anyone else want to add on? Okay tak? Okay, so remember, you need, and the other thing is, you need a systematic approach to differential diagnosis. I always stress this to all my students lah. So the way I use is, the way I do it is, I'm using the acronyms of vitamin A, B, C, D, E, K. Pernah dengar kan the acronyms kan? So you divide your differential into either by etiology or by anatomy or by physiology. Doesn't matter as long as there's a structure in it. Okay, even by medication, by treatment pun boleh. Okay, for example in this case kan, patient datang dengan fever with pelo. Okay, fever with pelo. So what is the differential diagnosis? V, vitamin. Okay, vascular. Is there any vascular causes of fever and pelo? Okay, we cakap lah hemolysis kan. Hemolysis lah, maybe hemolysis, GCPD ke. Thalassemia, okay lah, boleh lah juga thalassemia. Okay, and then apa lagi? Vitamin I, infectious. Infectious should be at the top of the list. Infection and also malignancy. Okay, infection such as, apa infection yang can datang dengan pelo, and then high total white? What sort of infection yang affect you punya pelo lah, yang cause pelo?
Malaria?
Malaria ya, Malaria selalunya dia datang dengan prolonged fever lah. This one only 5 days. Malaria, I don't think so lah. Malaria dia datang dengan pelo, tapi dia tak high total white. Maksudnya malaria tak high total white. Okay, ada high total white. You can get, you know, the atypical infection, mycoplasma. Okay, anything kan, you tak tahu, you just mention mycoplasma, it's okay. You'll get, you won't be penalized because there is a master in disguise. So mycoplasma, and then parvovirus, It's common parvovirus lah. Parvovirus is the culprit lah, selalu macam ni. Parvovirus, pasal apa lagi? That's why rashes is very important kan. Slap cheek disease. Tapi parvovirus lah, B17 yang common. And then apa lagi infection? Okay, ada few infection yang cause pelo N ni, high toto white. Tapi high toto white lagi satu yang paling common is pertussis lah. Tapi this child dia tak ada pertussis punya symptoms kan. Dan kalau patient ada cough, barking cough, prolonged cough, and then ada high toto white, top of the list will be pertussis. Okay, only pertussis yang you boleh dapat. Not many infection yang you boleh dapat. Toto white up to 200, 100 plus it'll be pertussis. Okay, and then infectious. And then T, trauma tak ada. A, autoantibody. You boleh letak GSPD, boleh letak dalam. Atau GSPD bukan autoantibody. Hemolysis lah, hemolysis kan, autoimmune hemolysis ataupun AIHA ke, cold AIHA ke, warm AIHA ke. And then M is metabolic. So is there any metabolic condition that can present with this? Pelo, not much lah actually. Okay. And then I, idiopathic. N is apa? Neoplasm kan, especially leukemia. So you can divide. Okay, the differential diagnosis for this case is I divided the differential diagnosis according to etiologies. Okay, for example, vascular causes of etiologies such as blah 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 blah. Okay, infectious causes such as blah 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 blah. And then neoplasm such as blah 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 blah. Okay, and then lymphoma is quite unlikely in this case. Okay, lymphoma you need lymphadenopathy lah to diagnose lymphoma. Either a group of lymph nodes ataupun isolated lymph nodes. But the only point that I'm thinking of lymphoma is the snoring tu lah. Because I thought it's something like obstruction of the airway because of thoracic, intrathoracic lymph nodes. Okay, tu lah. Okay, otherwise okay kot. Okay, shall we continue on the next one? Siapa?
Me.
Okay, okay, good. Idlan. Kejap. Can you give me like 5 minutes? Kejap
Okay.
People got the titik cover. Let it tutup.
Okay.
Okay.
Yes, jom.
Okay, boleh nampak?
Boleh?
Okay, so this is my patient identification, Farah Sufia, 6 years, 4 months old. So source of clacking is from patient's mother. So for the chief complaint, Farah Sufia, a 6 years old Malay girl with underlying cerebral palsy and also GERD, was brought to the emergency department of IMC with complaint of rapid breathing for 1 day, preceded by cough for 6 days, also fever for 2 days duration. So for history of presenting illness, patient was relatively well until 6 days prior to admission. She developed sudden onset of cough after drinking meds. It was productive in nature with clear sputum but no any blood noted. It also associated with post-tarsic vomiting of the milk. Then the cough from the first episode of cough became intermittent and not resolved after that. And the mother did not take any medications to relieve the symptom. And 4 days prior to that, the symptom become yellowish in color. However, there was no any blood. Otherwise, for this cough presentation, there was no any barking or whooping cough, no any facial congestion or any bluish discoloration. And along with the cough, Farah developed loss of appetite, which normally she will drink Pediasure for about 4 ounces per serving for 3 times per day. However, due to this current condition, she refused to drink because of the cough, tolerating only half of the daily meal. Okay. On 4 days of the cough, she then developed fever, which was persistent in nature, associated with chills and rigor. And then the mother brought her to general practitioner, and she was given antibiotics, syrup paracetamol, and also per-rectal paracetamol. His mother also tried to relieve the fever by tepid sponging. However, upon the treatment, the fever was only partially relieved, and the documented temperature was not remembered by the mother. Okay. And on the day of admission, she developed sudden onset of rapid breathing. It also associated with irritability and lethargy. However, there was no any added sound noted such as stridor or also wheezings. So pertaining to these symptoms, she was brought by her mother to ED for medical attention. Further questioning, this was her first admission for this symptom presentation. Her mother also noticed that she usually had difficulty of swallowing of milk and sometimes choking of milk since 1 month old. However, she was not fed by any tube feeding or any alternative feeding lah. So otherwise, her mother denied of any feeding episode prior to the drinking milk, no any neck swelling or neck mass noted, no other URTI symptoms, no any sick contact or history of travelling, no history of atopy or family history of atopy, and no other system was unremarkable. So regarding the cerebral palsy, she was admitted to an ICU after birth for 5 days due to hypoxia preceded by prolonged labour. Then she discharged from an ICU and admitted to pediatric wards for another 11 days. CT scan and MRI were done, and her mother was told that she had brain injury. At age of 1 month old, she was diagnosed with dystonic cerebral palsy and was followed up at HTA once every 3 months. She also had multiple episodes of fainting since 4 months old and was given anticonvulsive syrup and continued the medication till 2 years old, and the symptom of fainting resolved. Regarding the GERD, she also was diagnosed with GERD since 1 year old at HTA with complaint of vomiting, lethargy, and also poor oral intakes. And she was admitted for 2 weeks at pediatric ward. However, the mother unsure of treatment given. For the past medical and surgical history, other than cerebral palsy and also GERD, she was electively admitted for 11 tooth extraction. It was uneventful. Otherwise, there was no any other chronic illnesses. For drug history, she was on regular medication of ranitidine 2 times daily for GERD. Otherwise, there was no any known drugs or food allergy, not taking any supplement or alternative medication. For birth history, antenatally was uneventful as the mother had no any comorbidities such as GDM or hypertension during pregnancy. Intrapartumly, the child was born through vacuum-assisted delivery at 40 weeks of gestational age. Her birth weight was 2.89 kg. Postnatally, despite of admission of an ICU mentioned earlier, her mother denied of having any medical condition. For nutritional history, she was exclusively breastfed until 1 month old. Then she started with formula milk and currently was on Pediasure until now. And she started weaning on with Nestum at age 1 year old. However, discontinued because she cannot tolerate solid food till now. For the growth and developmental history, for the gross motor, she unable to ambulate herself, cannot walk or crawl, and needs special wheelchair. For fine motor, Andy can do palmar grasp. For speech or language, he she can turn her head to sound and babbling in single syllables. For social, cannot fit dress or toilet training by herself. And for my conclusion, this correspond to global developmental delay, with age correspond to 6 to 7 months old. Currently, she is grade 1 student at Pendidikan Khas Taman Guru Kuantan. For immunization history, she was vaccinated according to immunization schedule of MOH Malaysia. No any complication despite of vaccination. For the family history, she was first daughter from 2 siblings. All other family was no any medical illnesses. His father had no 38 years old, and his mother was 36 years old. For her youngest brother, also no any non-medical illness, no any same history of same symptom like her. Okay, for social history, currently they live at Indra Sempurna, Gambang, with her parents and her younger brother, with total of 4 occupants. So make it household income for both parents is about 5,000 per month. So in summary, my patient, 6 years old girl with underlying cerebral palsy and also GERD on ranitidine, currently admitted due to choking of milk for 6 days duration, worsened with fever and yearly sputum for 2 days duration, and preceded by rapid bleeding on day of admission. So for physical examination was done on day 3 of admission. She was conscious and alert, lying comfortably on bed with her mother at periphery. She appeared tachypneic, but not any other sign of respiratory distress, not any pain. There was branula attached at left dorsal of hand with active infusion of IV penicillin. However, there was no any other attachment. And on peripherally, there was no any finger clubbing. Capillary fill time less than 2 seconds, no any jaundice or pallor noted. There was angular stomatitis noted, but no white coated tongue, no enlarged tonsil, no any cyanosis, no palpable lymph node, no any neck mass, and also no pedal edema. So for the vital sign, all was normal except for respiratory rate was tachypneic, 30 breaths per minute, and also the patient was febrile, 38.8 degrees Celsius. Anthropometric measurement, this patient have below 3rd percentile for weight and height with 10 kilogram and also 19 centimeter respectively. So my conclusion in this patient is having failure to thrive. So I focus on respiratory examination. For inspection, the chest move with respiration, no any chest deformity noted, and no any scar, no subcostal or intercostal recession noted. Wheezing was not heard. On palpation, the trachea was centrally located. The chest expansion was equal bilaterally. The tactile vacuum parameters was reduced at middle and lower zone of right lung. And also there was dullness of percussion on the same zone. Plus with crepitation was heard over the middle and lower zone of lung. Otherwise, the air entry was good, equal both sides. For neurological examination, because of the patient of cerebral palsy, so on inspection, there was abnormal posture, flex and also decorticate of both upper and lower limb. However, unsure whether he has contraction or tremor. For upper limb examination, there is hypertonia of both upper limb with power at least 3, and there are hyperreflex and also presence of spasticity. Same with the lower limb with hypertonia, power grade of 3, at least 3, hyperreflex, and also presence of spasticity and Babinski sign. Otherwise, other systems were unremarkable. So in summary, on physical examination, the patient was febrile, tachypneic, and also there was evidence of consolidation, with the evidence of right, middle, and lower zone finding of reduced vocal resonance, vocal fragmentus, dullness on percussion, and also crepitation, with neurological deficit of spastic quadriplegia. So my professional diagnosis will be aspiration pneumonia, secondary to possible bulbar palsy with underlying cerebral palsy. Points 4 because of the symptom of suggesting of aspiration pneumonia, which is cough, potassium vomiting, fever and also rapid breathing, and also associated with lethargy and also lost appetite. The patient also have history of difficult swallowing and choking, might suggest of possible bulbar palsy, and also history of hypoxia might indicate HIE with the cause of cerebral palsy. The patient also have failure to thrive because of this difficulty of swallowing, and consolidation for aspiration pneumonia for right lung by the presence of physical examination suggests this diagnosis. However, there was no any symptom of drooling of saliva that might indicate bulbar palsy in this patient. Okay. My other differential diagnosis that I might think is because of the patient have GERD might be aspiration pneumonitis due to the gastric content, and because the patient might have esophagitis lead to esophagus stricture. Other differential diagnosis might be aspiration pneumonia secondary to laryngomalacia, because laryngomalacia commonly have difficulty in swallowing, but the points again in this case, the patient doesn't have stridor and also did not have snoring when sleeping. And other possible diagnosis of pneumonia itself, which is right lobar community acquired pneumonia, because of the presentation of examination direct to right lobar community acquired pneumonia. Okay, so for investigation, first of all, I would like to do full blood count to look for any evidence of infection. So in this case, we can see that the white blood cell is high with 15/4 with high neutrophil and also monocyte, might suggestive of bacterial infection. However, I'm not sure why the platelet is low, but it's at the upper border of low lah. For the renal profile, because of the patient have lost appetite, difficulty in swallowing, I suspect of electrolyte imbalance, which can see they have hyponatremia, hypokalemia, and others electrolyte imbalance. For chest X-ray, you can see there is slight consolidation in the right middle and lower zone of the lung with some haziness and a bronchogram. Other part was unremarkable. So, and then there was inflammation test, which is C-reactive protein, which is increased, indicate of acute inflammation. And also I want to do sputum culture and sensitivity to look for the causes microorganism for this patient for specific antibiotic later, and also blood culture and sensitivity. And for other differential diagnosis size GERD, I want to do OGDS to look for any esophagus stricture due to esophagitis, and also laryngoscopy to look for laryngomalacia to look for sign of omega, but it was not done in this patient. Okay, so for my management, basically for acute management, I would like to stable the patient by the secure the airway, breathing and circulation. So for the securing the airway, I would like to give oxygen therapy by non-invasive means in ventilation, such as nasoprong or venturi mask. Rehydration, because of the patient have electrolyte imbalance, so I would like to give rehydration IV normal salines, and check for input-output chart. And for fever, I would like to give syrup paracetamol to relieve the fever. If the patient cannot tolerate early, I would like to give IV paracetamol. And for infection, because of this case of pneumonia, I like to give IV penicillin. If the patient have allergic to penicillin, I like to change to IV cefuroxime. For the intakes, I would like to consider NG tube feeding to avoid any aspiration later. So for the long-term management, I would like to refer this patient to the chest physiotherapy, and also to continue physical and occupational therapy for cerebral palsy, continue Ranitidine for GERD, and also consider alternative feeding to avoid aspiration, might be NG tube feeding or gastrostomy feedings. I think that's all for my presentation.
Very good, very good. Okay, good. Okay, so start dengan Nadia Ardila. Okay, what what's good about the presentation?
Okay, for me, what's good about presentation is Idlan, he separate the part, underlying of this patient so that he explain according to the pathology, so that we don't confuse ourselves. And then what I want to know more is regarding her CP. She's already 6 years old, but she never on tube feeding. So I want to know whether she's undergo follow up regular physiotherapy or anything that been taught to the mom for her child management before this admission, because it seemed like there's no information regarding her progress of CP for 6 years.
That also I curious because I take it from case write up before lah.
Okay, 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 okay. Okay, good, 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 good. Okay, Haziq, any taken? Any comment?
So basically for the comment, I like the way lah. He presented chronologically just like before. Not too long, not too short, just nice. And for the development history, I love it because very detailed. Plus, he give the condition that the patient experience, such as the global developmental delay. So other than that, I don't know.
So give conclusion, right? After, I mean, give his
Yes, the
conclusion.
conclusion.
Okay, that's good, good. Okay, Rahil? Anything good?
For me, it's good. I like the way he explained each of the symptoms, like very detailed. For example, like cough, here he said like productive, blah 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 blah. But it's very detailed for every symptoms that he mentioned, and I also agree that he also give his conclusion, whether for the investigation and so on.
Okay, good, good. Okay, Tonton Shazwani? Shazwani?
I think my comment like other of my colleagues. So he explained detail every symptoms, everything that he write. mm.
Guys, sekejap bagi saya dalam 3 minit kejap je. Okay, guys, actually I'm so sorry because suddenly I've got a patient datang. So I got clinic hari ni. Anyway, so Uh, I think okay, let me just give comment tak. Kita saya janji 10 minit dengan patient. Okay, dengar kan?
Dengar Doktor.
Okay. So in general, that's a very good presentation. I really like it, especially the fact that you introduce the patient first. Okay, because sometimes when you present a case, you need to give some idea to the listener. What are you? I mean, the background of the patient. So it's very good to say with underlying. You've mentioned underlying CP, but you can improve a bit by mentioning how severe is the CP. Okay, because if you say a child with hemiplegic CP or maybe a diplegic CP kan, diplegic CP datang with GMFCS, itu GMFCS, CFCS semua tau. Okay, so GMFCS level 1 datang dengan this presentation, then the first thing in my list is actually infection. Okay, tapi kalau with level 5 GMFCS and then also quadriplegic CP, bedbound, fully dependent, then the first in my diagnosis, the first at the top of the list is actually aspiration lah. Okay, faham? Okay, but that's very good start. And you also mentioned not on tube feeding. If you mention this earlier, then it'll be better. Okay, you did mention later lah after waktu past medical history as well. And then the development history is very good. I think overall it's very good presentation. Cuma in terms of diagnosis, I think aspiration is the first. You have to be clear when you present about the cough. Is it really cough atau is it choking? You mentioned cough after feeding kan?
Yes.
Tapi you can actually just say ada choking.
Make sure choking terus.
Cakap ada choking. Ada cough and also choking. You sebut choking. You kalau you tak sure sebut cough juga, tapi you boleh sebut choking terus. Because choking, everyone know what is choking is. It's not something I will diagnose. It's actually patient tell us they choke. Okay. And then you kena tanya previous choking episode memang selalu choke ke? Because patient with GERD, dia memang akan selalu choke. Okay. Tapi you have to understand, GERD doesn't mean they've got swallowing problem. Okay. It doesn't have to come together, because choke can present separately then GERD. Okay. Cuma aspiration can come with both. Okay, aspiration can come with choke. Usually choke akan lead to aspiration, and also GERD can lead to aspiration. But usually GERD they become micro aspiration. So they have micro aspiration. Okay. And then apa lagi? I'm going to jump. I mean, it's not going to be very organized because I'm quite distracted with the patient just now. So anyway, ranitidine kan? Ranitidine, you mentioned about ranitidine. Actually ranitidine I rasa macam dah tak boleh guna. Recently kita boleh guna balik. Tapi so far kita dah stop guna ranitidine. Okay. And then apa dia? Oh, you mentioned about the hypoxia kan? What do you mean hypoxia at day 5 of life? Macam boleh hypoxia at day 5 of life?
Nak indicate HIE tu. Tak tahu nak cerita macam
mana. Macam mana day 5 of life? Patient well, term baby kan? Born well, tak admitted, tiba hypoxic.
Tak, patient admitted to NICU after birth and admitted for 5 days.
Sebab?
Hypoxia.
HIE ke apa?
Mungkin lah.
Because HIE sampai jadi CP macam ni, usually they mesti admitted for few days, for a few weeks pun. Kalau admitted for 5 days macam mild HIE rarely dapat ni lah. I think there must be something else happen, tapi tak pernah. Okay, and then the BP is very high. Actually, 122 is high. I don't think this is normal to her. Okay, check back. Okay, the BP is high. And then you've mentioned tactile vocal parameters. Can increase tactile vocal parameters. Okay, first, this child, I believe, the CFCS, the MSCS, I don't think she can communicate
Hmm.
uh, verbally with the mom, kan?
Hmm.
Then how are you assessing the vocal parameters? You may assess the tactile parameters, which I'm not sure how tactile pun tak tahu macam you nak check, kan?
Okay.
Okay, vocal and tactile parameters, and then dia tak correlate dengan your findings sebab you kata consolidation. Okay,
Hmm.
consolidation vocal parameters should increase ke reduce in consolidation?
Reduce.
Yeah, reduce. I think it's increase.
That's all.
Vocal resonance increase,
Uh-uh.
kan? In consolidation, vocal resonance increase. Okay. Tactile parameters, I rasa reduce. I tengok dah. I rasa parameters reduce. You check balik lah, tapi I rasa macam something tak betul lah. And then you mention kalau for infection you cakap kalau allergic to penicillin you bagi cefuroxime, kan?
Mm-mm.
Okay. In practice we don't do that. Okay, kalau allergic to penicillin kita tak bagi cephalosporin, kita akan bagi other group, and most of the time is macrolides lah, which is ES. Okay, ES or azithromycin. Okay, because dia ada cross allergic lah. Okay, this is more to management. And then the differential diagnosis also, you've got, I think you put a lot of thinking. That's very good. You put a lot of thinking on come up with the differential diagnosis. But I think there's a bit of confusion there. For example, laryngomalacia, kan? Okay, laryngomalacia ni is a developmental problem. I mean development of the ni lah, is the of your vocal cord, kan? So you don't diagnose patient is well from birth and then suddenly develop apa tu laryngomalacia. No, it's something that you diagnose at birth. Because laryngomalacia it resolve after a while. Most baby that require, even those yang require trachea tube, it reversible lah. So after a while we can remove the trachea tube once the malacia airway become hardened. Because malacia ni basically I mean the delayed in what you call it, in the hardening of the ligaments of the vocal cord. So it's something yang temporary. Because kalau patient ni ada laryngomalacia, dia ada stridor from beginning, okay, from lahir. So and then I think there's some confusion about the bulbar palsy, because bulbar palsy is lower motor or upper motor?
Because apa?
Ya ke apa?
Hmm.
Because the best of my knowledge, I think bulbar palsy is lower, is pseudo bulbar palsy is upper. In patient with upper motor neuron lesion, especially macam CP kan, they got pseudo bulbar palsy because it's actually at the upper up lah, at the medulla semua benda lah, at the brainstem. So it's not problem at the cranial nerve. Okay, bulbar palsy is cranial nerve punya problem. It's similar to Bell's palsy lah. Bell's palsy is facial nerve. Bulbar palsy is cranial nerve 10, 9, 11 macam tu. Okay, but that's very good thought you've put. Okay, tulis satu. And then for management, okay, patient with aspiration. Okay, this child is aspiration lah. You can confidently say this is aspiration. Okay, choking not necessarily leads to aspiration, tapi aspiration usually preceded by choking. Okay, choking or reflux. Okay, and then apa tadi? So you can actually mention aspiration. So the way you manage include the investigation lah. Investigation for aspiration is you can do OGDS. There's two ways. Okay, you can do OGDS. OGDS can be both diagnosing and therapeutic, and also prognosing. Okay, OGDS is a gold standard lah. But we don't. There's not many. Kalau you minat untuk jadi gastroenterologist, you can be pediatric gastroenterologist lah. Kat Malaysia ada 3 orang je, and one baru je retire, so we've got only 2 lah. 2 ke 3? 2 kot. Okay. Mungkin ada 3 kot. Okay, anyway. So, tapi usually what we do is less invasive. Kita buat barium study lah. Okay. Barium study. So basically we look at reflux. Okay, kita tengok reflux to diagnose GERD lah, GERD and also reflux. So barium study. Atau gastrographin macam tu lah nama dia, dengar lah. Tapi barium study lah. Rather, and cuma usually because patient dah 6-year-old, previously memang not on tube feeding, then the first step is swallowing assessment. Okay, you have to assess the swallowing first. Okay, and then kalau dia tak boleh swallow, baru you suggest feeding tube lah, feeding tube ataupun pad atau button lah. Okay, macam tu lah. And then pneumonitis, okay, aspiration pneumonitis, they can have fever lah. Usually they can have fever, tapi then they don't have obvious sign of infection. Like in this case, from the investigation, I think you check up memang ada obvious sign of infection, then you can say just pneumonia, aspiration pneumonia. Okay, lagi satu last point. Okay, last point is your examination. Sorry, I miss the examination. Okay, when you examine a child with CP kan, with a chronic disease, neurodevelopmental disease, okay, you have to examine, when you examine lah any child, your agenda is first to come up with a diagnosis, to support your history, to come up with a diagnosis, and the second agenda is to find complication. Okay, either complication from the acute problem or complication from the underlying problem. Okay, in this case, complication of acute problem you dah mention tadi lah, the reduced breath sound dan semua benda tu kan, and tachypneic. So that's a complication of pneumonia itself. And then complication of a chronic problem, you have to explicitly look for. Okay, contoh kan, patient macam CP, quadriplegic CP ni kan, you kena tengok for scoliosis. Okay, these are the thing that will have prognostic factor. Okay, kalau patient ada scoliosis, then you tahu dia akan mati in 30 years, less than 30 years dia akan mati. Okay, dia akan start ada pulmonary hypertension, dia akan ada recurrent infection, pneumonia. And then patient ada scoliosis and then ada aspiration pneumonia, and this is poor prognosis. Okay, scoliosis and then abdomen, you kena tengok ada constipation. Okay, ada drooling saliva. Kalau sign of swallowing problem kan, dia ada drooling saliva. Okay, you've mentioned, you kata tak ada stridor kan, then that's good. You boleh kata tak ada stridor, is good lah. Okay, lepas tu apa lagi blindness. Kalau you boleh kata patient is not focusing, then possible patient ni ada cortical blindness. Okay, this need practice and need reading. Okay, and then what else, yang lain tu, patient ni memang quadriplegic bukan diplegic
Quadriplegic.
Okay lah, because quadriplegic. Okay lah. And then microcephaly is very important. Okay, patient we should expect patient with this kind of severe hypoxic insult causing CP ni, dia mesti ada microcephaly. And you don't diagnose failure to thrive based on one reading, okay, one measurement. Okay, you can say patient is small for age. Patient is small for age. I would like to confirm whether patient is failure to thrive by plotting the growth chart. So you have to look at the trend. Definitely patient with quadriplegic CP, most of the time they are small from beginning. Okay, they are not because of failure to thrive, but it's actually from the beginning lah, they are small from beginning. Especially the head lah, the head circumference. Okay, rasa tu cukup. Anything else you want to add?
No.
Sorry lah, ada beberapa minggu kat sini tak pernah ada patient, tiba-tiba hari ni ada pula patient. Okay, ada lagi soalan? Any question?
Doktor, untuk cerebral palsy ni macam how detail macam management kita nak kena tahu pasal cerebral palsy?
There's a problem. Because this is something common, okay? This is something common and definitely will you get this case in your exam, okay? So try to go very deep. Okay, don't go superficial. Okay, because that will distinguish you from others. Okay, when I say deep, okay, look at the social aspect, look at the management of the chronic, because usually patient with CP ni they don't have much acute problem, they've got more to chronic problem. They, especially itulah epilepsi, kalau dia hemiplegic biasa akan ada epilepsi lah. Quadriplegic ni biasa more to dystonia macam tu. Biasanya epilepsi, constipation, feeding problem, growth, ni benda ni you have to tackle. In your long case you have to tackle this because this is something yang chronic lah. How depth? Try to be depth as possible. Okay, you may not, I mean tak adalah sampai botox benda, that's beyond the discussion, ataupun apa tu, muscle relaxing ataupun baclofen ke kan, antispasmodic, baclofen benda macam ni, yang tu maybe tak perlulah sampai situ, tapi the basic macam constipation, epilepsi yang tu you kena tip top lah kot. Okay, and then tu juga cuma examination lah, examination of patient CP may not be straightforward. Okay, even any patient pun lah, patient yang datang dengan pneumonia ke, kalau you tahu dia dah ada underlying something, bila in long case, because you have to examine whole system kan in long case, then you have to find the complication. Bed sore, okay, which is very common. Any patient yang chronic lah, especially yang bed bound, you kena tengok benda-benda ni. Okay? Okay, anything else? Okay, so kalau tak ada apa-apa, kita boleh tanggung. Kalau you guys ada question, you can always WhatsApp me lah. Okay, okay, kita tanggung dengan, anyway, congratulations, very good presentation both. Okay, kita tanggung dengan tasbih kafarah dan suratul nas. Allah.
Thank you very much, Doctor.
Thank you, Doktor.
Thank you, Doktor.
Okay, doktor.
Saya nak leave.